Welcome to the Deep Dive. Today, we are synthesizing a stack of anatomical and surgical texts, and we are really anchoring this whole discussion on the definitive textbook of head and neck anatomy by Gardner.
Yeah, it's a brilliant resource.
It really is. And we are building a mental model today of the vascular supply of the head and neck. But I am going to warn you right now, if you squeeze a pimple in the wrong place on your nose...
Oh, the danger triangle.
Exactly.
Hmm.
Or, if a dentist's needle slips just a fraction of a millimeter, you could theoretically introduce a fatal infection directly into your brain.
Which is a terrifying thought.
It's completely terrifying.
Right.
So today, our mission is to map out exactly how and why that happens.
And I think that is the perfect anchor for our discussion. If you are listening to this and picturing the circulatory map of the head and neck as, I don't know, a simple plumbing system with rigid, predictable pipes.
Right.
Just erase that image completely. We are dealing with a living geography here. It's more like a network of rivers.
A network of rivers, I like that.
Yeah, you have the arteries that relentlessly deliver life, surging with really high pressure, and then the veins that quietly, sort of passively return it.
But where blood flows, life is sustained.
Right. Absolutely. But also, where it flows, danger can travel unseen.
Which means rote memorization of a textbook map is just entirely inadequate for what we're doing.
Yeah.
We aren't just listing off Latin names today.
Oh, definitely.
We are studying structure in service of function. We really want to understand the architectural why. Why can a tiny clot cause instant blindness?
Or why facial trauma can cause a catastrophic airway flood.
Spot on. We are building a three-dimensional roadmap so you can actually anticipate potential catastrophic failures and understand life-saving interventions.
Right, and to construct that 3D model, we really have to first establish the primary highways.
The main delivery routes.
Exactly. On the arterial supply side, your head and the neck rely on three main sources. You've got the subclavian artery, the external carotid artery, and the internal carotid artery.
Okay, so that's the delivery. What about the return journey?
For drainage, the system relies primarily on the internal and external jugular veins.
Let's start from the ground up then. Before we even reach the intricate branches of the face, we have to trace the blood from the heart.
We do.
Now, if I am visualizing the major vessels leaving the top of the heart, the aortic arch, I would just assume there is perfect bilateral symmetry, a left pipe and a right pipe.
And you wouldn't be the only one. That is a really common assumption, but the reality is fundamentally asymmetrical.
Wait, really? Asymmetrical?
Yeah. The right and left sides of your neck do not get their blood from mirrored origins.
It's fascinating.
On the right side, the common carotid artery and the subclavian artery branch off a single shared trunk coming off the aorta. We call that the brachiocephalic trunk.
Okay, so they share a starting point on the right.
But on the left, the common carotid and the subclavian arteries arise independently. They are two completely separate branches straight from the arch of the aorta itself.
So why the asymmetry? I mean, the human body usually loves symmetry. Does the left side just have further to travel?
It's entirely an evolutionary adaptation, really, to the crowded real estate of the upper thorax.
Ah, I see.
During fetal development, as the heart descends into the chest cavity, it essentially drags these vessels with it. The aortic arch sweeps to the left.
So it's a space-saving measure.
Exactly. To save space and maintain efficiency on the right side, the body consolidates the two right-sided vessels into one short, thick trunk before they split.
Which means the left common carotid does indeed have a longer journey.
It does. It starts down in the thorax and has to travel all the way up to the sternoclavicular joint just to enter the neck.
But once both common carotids actually enter the neck, I'm assuming they play by the same rules.
They absolutely do. They ascend the neck within this tough, connective shrink wrap called the carotid sheath.
Right, the carotid sheath.
Yeah, and this fascia binds the common carotid artery together with the internal jugular vein and the vagus nerve.
A little anatomical bundle.
Precisely. And here's a non-negotiable anatomical rule. As the common carotid travels up the neck, it gives off absolutely no branches. Zero.
None at all. It's just a sealed transit pipeline then. It completely ignores all the surrounding muscles and glands in the lower neck.
Completely ignores them. It remains a sealed pipe until it reaches the superior border of the thyroid cartilage.
Which is the anatomical landmark everyone knows as the Adam's apple.
Spot on.
And that is where the great bifurcation happens. The common carotid splits into the internal and external carotid arteries. But Hyatt and Gardner make a real point of highlighting that this junction isn't just a simple fork in the road.
No, it operates as a highly sophisticated sensory station.
Because the brain is just so completely dependent on a very specific, uninterrupted flow of blood.
Exactly. At this bifurcation, there is a slight physical swelling in the vessel wall. We know this as the carotid sinus.
This is the baroreceptor, right?
Baro meaning pressure, yeah. The wall of the carotid sinus is incredibly thin, but it is completely packed with sensory nerve endings from the glossopharyngeal nerve.
So it's measuring stretch.
Yes, its sole purpose is to constantly monitor the hemodynamic stretch, the physical outward pressure of the blood heading towards your brain.
And nestled right next to it, tucked deeply in the actual crotch of the split, is the carotid body.
Right. And if the sinus is measuring physical pressure, the body must be measuring something else.
It's a chemoreceptor.
It is. It's a tiny reddish-brown structure, roughly the size of a grain of rice, innervated by both the glossopharyngeal and vagus nerves.
So instead of stretch, it's monitoring the chemical composition of the blood.
Exactly. Oxygen tension, carbon dioxide levels, and hydrogen ion concentration.
Like a tiny, real-time chemical analysis lab.
That's a great way to put it. It constantly samples the blood to ensure the brain receives the absolute optimal balance of oxygen and pH.
Which brings us to our first major clinical correlation. If we have a pressure sensor, the carotid sinus, sitting right there in the neck, what actually happens if it malfunctions or gets confused?
We see a condition known as carotid sinus syndrome. In some individuals, particularly older adults, the baroreceptors in the carotid sinus become wildly hypersensitive.
Hypersensitive to what?
Just mundane, everyday actions. Wearing a tightly buttoned collar, shaving the side of the neck, or even simply turning the head sharply to look for oncoming traffic.
Wow. So the mechanical pressure from the outside world actually tricks the internal sensor.
Yes, the sensor feels the physical squeeze of the tight collar and incorrectly registers it as a massive, dangerous spike in internal blood pressure.
And the physiological response has to be immediate, right?
It's immediate and dramatic. The hypersensitive sinus screams via the glossopharyngeal nerve straight to the brainstem.
And what does the brainstem do?
It reflexively triggers a massive parasympathetic response. It forcefully dilates systemic blood vessels to drop blood pressure, and it tells the heart to drastically slow down.
Or even pause momentarily.
Yeah, to compensate for this phantom pressure spike.
The result being a sudden, drastic drop in blood supply to the cranial vault.
Leading to syncope, a rapid, complete loss of consciousness. The patient simply collapses.
Just from backing a car out of a driveway.
Exactly.
That is a brilliant example of how local structure dictates systemic function. Now, before we follow those newly split carotid branches up into the face, we must address the other foundational arterial spring, which is the subclavian artery.
Right. The subclavian artery is famous for supplying the upper limb, but its proximal portion is a really critical lifeline for the deep neck and the posterior brain.
And to mentally map its path, we use a single vital muscular landmark, don't we? The anterior scalene muscle.
We do.
So if I am picturing the neck, the anterior scalene runs from the cervical vertebrae down to the first rib. So it acts like a thick structural column right in the lower side of the neck.
And the subclavian artery has to navigate around it. The artery passes directly behind the anterior scalene.
So the muscle essentially divides the artery's highway.
Precisely. It divides it into 3 distinct geographic zones. The first part is medial to the muscle, the second part lies hitting directly behind it, and the third part emerges lateral to the muscle before crossing the rib to become the axillary artery of the arm.
But wait, if the subclavian artery is ducking behind this thick, tight muscle, how does it service the structures in the central neck, like the thyroid, which are sitting right there in the open? Does the artery have to do a U-turn?
It does, in a way. Before the subclavian even hits that muscular border from its first part, it throws off several critical local exits.
So like local off-ramps.
Exactly. One of these is a short, thick trunk called the thyrocervical trunk. The moment it arises, it rapidly branches.
Supplying the thyroid.
Yes. One branch, the inferior thyroid artery, loops upward and medially, crossing the neck to supply the lower pole of the thyroid gland.
And the other branches.
Other branches, like the suprascapular and transverse cervical arteries, sweep laterally across the surface of the scalene muscles to supply the shoulder and upper back.
So it's a highly efficient distribution hub right before the artery dives deep.
It is. But there is another branch from that first part, and this one doesn't supply the neck at all.
Ah, you were referring to the vertebral artery.
Yes, the vertebral artery. This is the paramount branch for our cranial model. The vertebral artery ascends directly upwards, but it doesn't travel through the soft tissues like the carotid.
Right. It takes a much more secure route.
It threads its way into the transverse foramina. Those are the bony loops on the sides of the cervical vertebrae.
So it's literally climbing a bony ladder. Why encase an artery inside the actual vertebrae?
Think about the mechanics of the human neck. We can flex, extend, and rotate our heads to really extreme degrees.
Very true.
If this crucial vessel were simply floating in soft tissue, a violent whiplash or extreme rotation could just tear or kink it.
That would be catastrophic.
Exactly.
Okay.
By threading it through rigid bony rings, evolution protects the posterior blood supply to the brain, allowing it to bypass the chaotic, mobile, superficial neck entirely.
And then it just enters the foramen magnum at the base of the skull.
You've got it.
Okay, so we have our core framework. The subclavian is handling the deep neck structures and running that secure, bony route to the back of the brain. The common carotid has split. Let us now follow the superficial branch. The external carotid artery, or ECA.
The ECA is absolutely the workhorse of the head and neck.
The workhorse, how so?
Well, while the internal carotid is an exclusive express lane for the central nervous system, the external carotid is burdened with the massive, complex, and highly mobile vascular demands of the face, the oral cavity, the scalp, and the upper neck.
That is a massive territory. To handle that, it gives off 6 collateral branches as it travels up the neck, and then terminates by splitting into 2 final branches.
Right.
We need to visualize this, starting from the split at the Adam's apple and working our way up toward the ear.
The very first collateral branch arises almost immediately after the bifurcation. This is the superior thyroid artery.
But wait, if we are heading up the face, why does the very first branch head down? You mentioned earlier that the subclavian sends an artery up to the thyroid. Now the ECA is sending one down.
It seems counterintuitive, but we have to look at embryological development. The thyroid gland actually begins developing high up in the anatomy, right at the base of the tongue.
Oh, wow.
And it descends down into the neck as the fetus grows.
I see. So as it descends, it just drags its blood supply with it.
Exactly. So the superior thyroid artery essentially makes a sharp U-turn, descending alongside the larynx to heavily vascularize the superior pole of the thyroid gland and the surrounding strap muscles of the neck.
So it's basically an anatomical remnant of a developmental journey. That makes a lot of sense. What about the second branch?
The second is the ascending pharyngeal artery. It is the smallest branch, and it is tucked quite deeply on the medial side of the external carotid.
And where does it go?
It ascends straight up the muscular wall of the pharynx, supplying the throat, the soft palate, and it even sends tiny meningeal branches through the base of the skull to supply the dura mater.
Okay, branch 3. Now, this is where the structural mechanics get incredibly relevant, especially for anyone doing oral or dental surgery. The lingual artery.
The lingual artery is responsible for the tongue and the floor of the mouth.
Right.
To get there safely, it plunges deep. It passes deep to the hypoglossal nerve, slips underneath the hyoglossus muscle, and enters the deep protected surface of the tongue, supplying the muscle all the way to its apex.
Now, the tongue is arguably one of the most mobile muscular structures in the entire body.
Yeah.
The lingual artery must have to accommodate an immense amount of stretching and contracting.
It does. It cannot be taught. But its deep protected pathway usually keeps it relatively safe from superficial injury.
Usually.
Yes, usually. However, the lingual artery gives off a branch called the sublingual artery, which supplies the sublingual salivary gland and the mucosa of the floor of the mouth.
And this is where the textbook map can betray a surgeon.
Gravely. Imagine during a procedure in the floor of the mouth, perhaps an implant placement or a tumor removal, a vessel is accidentally cut.
Resulting in a massive pooling hemorrhage.
Exactly. The surgeon knows their anatomy. They locate the source of the lingual artery to ligate it, to tie it off and stop the bleeding.
But the bleeding doesn't stop.
Because clinical anatomy dictates that in a significant minority of patients, the sublingual artery does not arise from its normal source on the lingual artery.
Wait, really? Where does it come from then?
It arises anomalously from the submental branch of the facial artery.
Oh, wow.
So the surgeon is clamping the correct anatomical textbook location, but the wrong physiological pipe. The bleeding continues unabated until the surgeon recognizes the anomaly and tracks the collateral flow.
That is terrifying, but it perfectly transitions us to the fourth branch. You mentioned the facial artery. This one is famous in trauma and cosmetic surgery.
The facial artery is an absolute masterclass in functional adaptation. It arises from the ECA, passes deep to the posterior belly of the digastric muscle and grooves the back of the submandibular salivary gland.
You can actually feel this one yourself, you know?
Oh, yeah.
Yeah, if you trace your jawbone back towards your ear, just in front of the thick master muscle you use to chew, there is a small notch in the bone. You can actually feel the distinct pulse of the facial artery right there.
And that pulse point is critical because it is where the artery officially enters the highly mobile terrain of the face. And once it crosses that mandibular notch, its path becomes bizarrely tortuous.
Tortuous, like twisted.
Very. It wiggles, weans, and loops its way diagonally towards the corner of the mouth, ascends the side of the nose, and terminates at the medial corner of the eye as the angular artery.
If you look at an anatomical diagram, it really looks like a winding mountain road. But why not just run a straight line from the jaw to the nose? Wouldn't that be far more efficient?
Well, it would be more efficient for distance, absolutely, but it would be fatal for function. Consider the mechanics of the face. We chew, we yawn widely, we stretch our cheeks, we shout.
Oh, right.
If the facial artery were a straight, taut vessel, a wide yawn would physically stretch the vessel beyond its tensile limit. It would snap the endothelium and cause an internal hemorrhage.
So the tortuous winding is literally built-in slack.
Precisely. It is structural slack, and as it winds, it sends out the superior and inferior labial arteries, which course through the upper and lower lips.
The lips move constantly.
Because the lips are heavily utilized sphincters, these labial branches actually join together. They anastomose, forming complete pressurized vascular rings all around the mouth.
Okay, so we have covered the front and side. Superior thyroid, ascending pharyngeal, lingual, and facial. What about the scalp? The skin on the back of the head is stretched incredibly tight. It doesn't have the mobility of the face.
And the vascular network adapts to that rigidity. The posterior scalp and ear are supplied by the 5th and 6th collateral branches, which are the occipital and posterior auricular arteries.
Where does the occipital go?
The occipital artery arises from the posterior aspect of the ECA. It has to navigate a very dense muscular region. It travels deep to the sternocleidomastoid muscle.
The large muscle that turns your head.
Right, before finally piercing the dense fibrous fascia at the back of the neck to ramify or branch extensively across the tight skin of the posterior scalp.
Now the posterior auricular.
It arises a bit higher up, sneaking into the tight space behind the ear to supply the auricle itself and the adjacent scalp.
All right, so the external carotid has handed off all 6 of its collateral branches. At this point, it is now buried deep within the parotid salivary gland, just in front of your earlobe. And here, it reaches its end by splitting into 2 massive terminal branches.
The superficial terminal branch is the superficial temporal artery. It ascends out of the parotid gland, crossing directly over the zygomatic arch or cheekbone to supply the temple and the broad expanse of the lateral scalp.
This is another prominent pulse point. You can easily feel it right in front of the upper part of your ear.
It is heavily utilized clinically, too. If an anesthetist is monitoring a patient during surgery and the patient's arms are draped or access to the radial artery in the wrist is obstructed in some way.
You can just use the head.
Exactly. They can easily palpate the superficial temporal artery or the facial artery at the mandible to monitor the pulse rate and rhythm.
But it's the other terminal branch that really demands our full attention. The maxillary artery. You call this the heavyweight of the deep face.
It really is, because it supplies virtually everything the previous branches missed. It is a massive distribution system for the internal deep architecture.
Like what, specifically?
The upper and lower jaws, the roots of the teeth, the immense muscles of mastication, the deep nasal cavity, and even the tough outer covering of the brain.
That's a huge area.
It is. To navigate this vast territory, anatomical texts divide the maxillary artery spatially into 3 portions: the mandibular, the pterygoid, and the pterygopalatine portions.
Let's break those down. First, the mandibular portion. It's traveling deep behind the neck of the jawbone.
Its standout branches here are functionally vital. First, the inferior alveolar artery. This vessel actually enters a bony canal inside the lower jawbone to supply the roots of all the lower teeth before finally emerging at the chin.
And the second major branch from this portion leaves the face entirely.
The middle meningeal artery. And this is a critical structural vulnerability.
Why is that?
It travels straight up from the deep face and enters the cranial cavity through a tiny hole called the foramen spinosum. Once inside, it doesn't actually supply the brain itself.
Okay.
No, it supplies the dura mater, which is the thick fibrous membrane lining the inside of the skull.
So it's running right along the inner surface of the skull bone. Yeah. which means if you take a hard blow to the side of the head, say a baseball to the temple.
It's extremely dangerous. The bone at the temple, the diapterion, is incredibly thin. A fracture there can easily shear or tear the middle meningeal artery lying right beneath it.
Wow.
Because it is an artery under high systemic pressure, blood rapidly accumulates, literally peeling the dura mater away from the skull.
An epidural hematoma.
Exactly. It creates a rapidly expanding mass that compresses the brain tissue, constituting a profound, time-critical neurosurgical emergency.
From the teeth to a brain bleed. That is just the first portion. What about the second zone, the pterygoid portion?
This segment is entirely dedicated to the sheer mechanical force of chewing. The muscles of mastication, the masseter, the temporalis, and the medial and lateral pterygoids. They generate immense crushing force.
Which requires massive metabolic fuel.
Right. The pterygoid portion of the maxillary artery winds around these muscles, sending robust, dedicated branches into the muscle bellies to sustain that high-energy output.
And finally, the artery reaches its third zone. It dives into a tiny hidden cavern in the skull base called the pterygopalatine fossa.
The pterygopalatine fossa is like a hidden, high-traffic junction box. It is a tiny, bony room with multiple exit doors leading to different parts of the face.
Like a hub.
Once the maxillary artery enters this room, it explodes into terminal branches. It sends the posterior superior alveolar artery out to the upper molars. It sends the infraorbital artery straight forward, emerging just below the eye to supply the front of the cheek.
And the descending palatine.
Straight down to supply the roof of the mouth.
And crucially, it sends the sinopalatine artery through a medial door directly into the nasal cavity.
Which brings us to the mechanics of a very common, very messy clinical reality. Epistaxis, or nosebleeds.
We've all had a nosebleed. But why are humans so uniquely prone to bleeding from the nose?
To understand epistaxis, we have to understand the concept of an anastomosis. An anastomosis is where multiple distinct arterial networks converge, join together, and share their blood supply.
Right.
The anteroinferior region of the nasal septum, the wall dividing your nostrils, is home to a massive anastomotic hub called Kieselbach's area.
A convergence point.
A highly pressurized convergence point. In Kieselbach's area, you have terminal branches from the facial artery arriving from below, branches from the ophthalmic artery coming down from above, and the sphenopalatine artery rushing in from the deep maxillary system.
That's a lot of blood flow.
And the nasal mucosa overlying this area is exceptionally thin to allow for humidification and warming of the air we breathe.
So you essentially have a high-pressure vascular junction box sitting just millimeters beneath a fragile mucous membrane exposed to dry air, fingernails, and physical trauma.
Exactly why it ruptures so easily. However, most common nosebleeds occur here, and they are generally easy to control.
Why is that? If there is so much blood flow from 3 different major arterial systems, shouldn't it be quite difficult to stop?
Because of the structural backing. Beneath that thin mucosa lies the firm cartilage of the nasal septum. When you apply firm direct pressure by pinching the nose, you are physically compressing all those bleeding vessels against a hard, rigid backboard.
Which stops the flow long enough for a platelet clot to form.
Right. But not all nosebleeds are easily pinched away.
Right.
If a patient presents with severe epistaxis that simply cannot be controlled with interior pressure, the rupture is likely occurring deeper in the nasal cavity.
From where?
Originating directly from the main trunk of the sphenopalatine artery itself. Your pinching fingers cannot physically reach the deep bone to compress the vessel.
That sounds severe.
These posterior arterial nosebleeds are severe, fast-flowing, and frequently require a medical professional to insert expanding nasal packing, or, in extreme cases, surgically ligate the sphenopalatine artery in the pterygopalatine fossa to shut off the deep supply.
Wow. We've just navigated an incredibly chaotic, highly branched, tortuous network. The external carotid artery is clearly a busy, local distribution hub adapting to tight bones, mobile muscles, and deep cavities.
It is.
But now we leave the superficial face. We are entering the highly protected, privileged path to the brain, the internal carotid artery.
And the contrast in structural philosophy between the two systems is absolute. The external carotid branches everywhere. The defining anatomical rule of the internal carotid artery, the ICA, is that it has no branches in the neck.
None.
None. It ascends directly from the bifurcation, heavily insulated within the carotid sheath, completely bypassing every muscle, gland, and tissue of the neck.
Which, if you really think about it, feels entirely counterintuitive. Every other major artery acts like a delivery driver on a busy street, handing off blood to whatever tissue is nearby. Why does the ICA just ignore the neck?
Because of the absolute metabolic greed of the brain, let us look at the systemic numbers. The human brain constitutes roughly 2% of total body weight, yet it consumes a staggering 20% of the body's total resting cardiac output.
20%, that is massive.
It is. The brain does not store oxygen, and it cannot function on anaerobic metabolism. It demands a massive, continuous, high-pressure, high-volume flow of blood.
So the ICA is essentially an express lane.
Exactly. If the ICA gave off branches in the neck, every single branch would bleed off systemic pressure and volume before the blood ever reached the cranial vault. Evolution has engineered this massive branchless pipe solely to guarantee the central nervous system gets its required 20%.
So how do we actually track this non-stop express train? Hyatt and Gardner divide into 4 segments, right?
Yes, based purely on spatial geography. We covered the first, the cervical portion, which ascends the neck without branching. The second is the pitchus portion.
This is where it physically enters the base of the skull.
It enters the carotid canal, which is a tunnel bored directly through the dense, rocky petrous part of the temporal bone.
Okay.
But it doesn't just go straight up. Inside the bone, the ICA takes a sudden, sharp 90-degree horizontal turn.
Why a right angle? Why not a straight shot to the brain?
Fluid dynamics.
Ah.
The blood coming up the neck is under immense systolic pressure directly from the heart. If that high-pressure pulsatile wave slammed directly into the delicate vessels of the brain, it would cause shear trauma.
So the turn slows it down.
By forcing the artery to navigate a sharp 90-degree corner within a rigid bony canal, the anatomy naturally dampens the pulsatile force, delivering a smoother, more continuous flow to the cerebral tissue.
That's brilliant.
Even within this bony tunnel, it gives off only microscopic twigs like the caroticotympanic artery to the middle ear cavity.
That structural buffering is genius. Then it emerges from the bone into the third part, which is the cavernous portion. And this segment is structurally terrifying.
It breaks all the normal rules of vascular boundaries. The ICA passes directly through the center of the cavernous sinus.
Which is what exactly?
The cavernous sinus is not an artery. It is a massive, pooled lake of venous blood situated on either side of the sphenoid bone at the base of the skull.
Wait, so it's like running a high-pressure, boiling hot water pipe directly through the center of a calm, cool reservoir.
That is the perfect mechanical analogy. You have a pulsating, high-pressure arterial pipeline suspended inside a low-pressure venous swamp.
That sounds risky.
They are separated only by the thin endothelial lining of the sinus and the fascial sheath of the artery. While passing through this pool, the ICA supplies tiny but vital branches to the trigeminal ganglion and the pituitary gland.
If that hot pipe springs a leak, the whole reservoir violently pressurizes. We will absolutely return to that exact scenario when we cover the veins. But after the ICA survives the cavernous sinus, it reaches its final destination.
The fourth and final segment is the cerebral portion. It pierces the dura mater, finally entering the true cranial cavity.
And this is where it branches.
Here, it branches to form the anterior and middle cerebral arteries, supplying the massive hemispheres of the brain. But just before it makes that final split, it gives off one vitally important branch that actually leaves the brain cavity, the ophthalmic artery.
The ophthalmic artery travels alongside the optic nerve, straight through a bony canal into the orbit of the eye.
It is the primary vascular supply for the entire orbital apparatus. It supplies the extrinsic eye muscles that move your gaze, the lacrimal gland that produces tears, and the eyelids.
But its most critical job.
Its non-negotiable responsibility is the eyeball itself. It accomplishes this via several branches, but the one we must focus on clinically is the central artery of the retina.
Which brings us to a phenomenon clinicians call the sudden dark. Let's unpack the mechanics of the central artery of the retina.
The central artery of the retina is microscopically small. It actually pierces the outer sheath of the optic nerve and travels forward inside the core of the nerve itself.
Wow, inside the nerve.
Yes. When it reaches the back of the eyeball, it enters the inner surface of the retina and branches out like a spider web to supply the neural tissue that translates light into vision.
But unlike the nose or the lips or the scalp, where we saw massive anastomosis and overlapping redundancies, the retina doesn't have a backup generator, does it?
It has absolutely no backup. The central artery of the retina is what anatomists call an anatomic end artery.
Meaning?
Its branches do not form functional connections or anastomoses with any other arterial system. It is the sole exclusive source of blood for the inner retina.
That makes it incredibly vulnerable.
Because the vessel is an end artery, And because its physical diameter is so tiny, it is profoundly vulnerable to blockages.
Blockages like an embolus, let's say a tiny fragment of a blood clot or a small piece of calcified cholesterol plaque, breaks off from a larger vessel lower down, perhaps from the carotid bifurcation in the neck, or even from a valve in the heart.
That embolus gets swept up in the high-pressure express lane of the internal carotid. It bypasses the neck, navigates the skull, enters the ophthalmic artery, and is finally forced into the tiny central artery of the retina.
And then it gets stuck.
Because the vessel narrows, the embolus acts like a cork in a bottle. It wedges tight.
And because there is no anastomotic backup supply,
The blood flow to the inner retina is instantly, totally severed. The clinical presentation is unmistakable and terrifying. The patient, typically an older adult with underlying vascular disease, experiences instant, painless, total blindness in one eye.
a complete curtain falling over their vision.
It is an absolute medical emergency. If that embolic blockage is not dissolved or cleared within a few short hours, the oxygen-starved neural tissue of the retina undergoes necrosis. It dies, and the unilateral vision loss becomes permanent.
Structure serves function, but in the case of an end artery, structural isolation brings extreme vulnerability.
Very well said.
It perfectly illustrates the stakes here. We have mapped the delivery system. It is highly pressurized, strictly organized into territories with brilliant zones of redundancy and terrifying areas of isolation.
Right.
But the blood has delivered its oxygen. Now it needs to get back to the heart. We are flipping the script entirely. We're entering the venous return.
And to understand the veins, you must completely discard the mental model we just built for the arteries.
Discard it completely.
Completely. Blood delivery is an active, structured, high-pressure system driving fluid forward. The return journey is a passive, low-pressure, sprawling, interconnected swamp.
A swamp.
In the head and neck, the standard physiological rules of one-way traffic simply do not exist.
Now, if I think about the veins in my legs, they have internal valves. They have little physical gates that snap shut to ensure that blood only flows upwards against gravity back to the heart.
But in the head and neck, gravity is your ally. Gravity naturally pulls the venous blood down towards the heart.
Oh, of course.
Therefore, evolutionary pressure to develop one-way valves was minimal. Most of the major veins draining the face, deep head, and cranium have evolved entirely without these directional valves.
A system without gates. And the prime example of how this can go horribly wrong is the facial vein.
The facial vein is the principal drainage pipe for the superficial face. It originates right at the medial corner of your eye as the angular vein.
Just mirroring the artery.
Exactly. It essentially shadows the winding path of the facial artery, descending down the side of the nose, across the cheek, over the jawbone, and eventually emptying into the deep internal jugular vein in the neck.
But because there are no physical valves acting as gates, the blood in the facial vein isn't forced to only flow downwards.
And this is the crux of the danger. Fluid flows in the direction of least resistance. Depending on local tissue pressures, muscle contractions, or temporary blockages, venous blood in the valveless facial vein can flow in reverse.
It can flow upwards.
It can flow superiorly upwards toward the eye. And the facial vein is not an isolated pipe. It has multiple wide-open communications with deeper venous structures.
Not just.
It connects to the deep facial vein, and crucially, right at the corner of the eye, it connects directly with the superior and inferior ophthalmic veins.
The ophthalmic veins, which travel directly back through the bony orbit of the eye and drain straight into the cavernous sinus inside the skull.
Yes. The exact same cavernous sinus we discussed earlier sitting right beneath the brain, housing the internal carotid artery and multiple cranial nerves.
Wow.
This direct, valveless anatomical pathway from the surface of the face into the center of the skull creates what clinicians urgently refer to as the danger triangle of the face.
I remember learning this in anatomy and suddenly becoming absolutely terrified of every minor blemish I ever got.
It's a common reaction.
If you draw an imaginary triangle, with the top point resting between your eyes and the broad base spanning across your upper lip, you have outlined the danger zone.
The danger is purely mechanical. Let us trace a hypothetical infection. Suppose you develop a severe, localized bacterial infection right in the middle of this zone.
Perhaps from aggressively squeezing an infected boil on the bridge of your nose, or a poorly managed piercing on your upper lip.
Right. The local tissue becomes intensely inflamed. This inflammation can trigger the blood inside the adjacent facial vein to coagulate, forming a clot. This is called thrombophlebitis.
So it's a clot that is actively seeded with bacteria from the surface infection.
An infected thrombus. And because there are no valves to prevent retrograde flow, pieces of this infected clot can break off.
And flow backward.
The local pressure from the swelling pushes the venous blood backward. The infected emboli travel up through the angular vein, slip into the ophthalmic veins, pass entirely through the eye socket, and are deposited directly into the cavernous sinus inside the cranial vault.
You are taking a surface skin infection and delivering it via a direct, unimpeded highway, right into the space housing the brain.
The resulting condition is cavernous sinus thrombosis. It is a catastrophic, life-threatening crisis.
Because it's swelling inside the skull?
As the cavernous sinus violently swells with infected pus and clotted blood, it compresses the structures trapped inside or running along its walls. It compresses the oculomotor, trochlear, and abducens nerves, instantly freezing the patient's eye movements.
Oh, wow.
It compresses the ophthalmic nerve, causing excruciating pain. The massive fluid backup causes the eye to bulge forward, a condition called proptosis.
That sounds horrific.
If untreated with aggressive intravenous antibiotics, the infection easily breaches the thin dural boundaries, causing fatal meningitis or massive brain abscesses.
Just from a pimple. A structural reality, the lack of venous valves, creates a literal backdoor for pathogens.
It does.
And it isn't just the superficial surface of the face that harbors this risk. The deep architecture of the face has its own valveless interconnected swamp, doesn't it? The pterygoid plexus of veins.
The pterygoid plexus is immense. It is a dense, tangled, chaotic network of venous channels draped over and wrapped around the pterygoid muscles of mastication, sitting deep to your cheekbone in the infratemporal fossa.
What does it drain?
It receives the venous drainage from almost every structure the maxillary artery supplies. The nasal cavity, the roof of the mouth, the muscles, and all the teeth.
And just like the facial vein, this deep swamp communicates with everything around it.
It communicates superficially with the facial vein via the deep facial vein, but more alarmingly, it has deep emissary veins.
Emissary vein.
Dedicated valveless channels that pass directly through tiny holes in the base of the skull, connecting the extracranial pterygoid plexus directly to, you guessed it, the intracranial cavernous sinus.
So the exact same risk of retrograde brain infection applies, but a person can't squeeze a pimple on their pterygoid muscle. How does an infection usually reach this deep plexus?
The most common and direct clinical vector involves dentistry. To perform deep restorative work on an upper molar, a dentist must often administer a superior alveolar nerve block. This requires inserting a long needle deep into the posterior maxilla, right into the territory of the pterygoid plexus.
And because it is a massive, tangled web of veins, it must be remarkably easy to accidentally nick one with the needle.
It is a known risk. If the needle trajectory is slightly off or inserted too deeply, it pierces the thin-walled veins of the plexus.
What happens then?
This immediately results in blood rushing out into the tissue spaces, creating a rapidly expanding, deeply bruised swelling inside the face known as a hematoma.
The swelling is painful, I'm sure, but the greater danger is what the needle might have brought with it.
Precisely. If the needle tip was contaminated, or if the injection technique inadvertently tracked bacteria from the non-sterile oral cavity deep into the tissue planes, that needle tract introduces an active infection directly into the venous plexus.
And from the plexus, those emissary veins provide a valveless, open door straight up through the skull base into the cavernous sinus.
A routine, everyday dental block, if performed improperly or under poor sterile conditions, can theoretically introduce a fatal intracranial infection. The anatomy is completely unforgiving.
So all this venous blood from the valveless facial veins, the deep pterygoid swamps, and the brain itself eventually has to find its way down the neck and back to the heart, which brings us to the main drain pipes, the jugulars. We have the internal and the external.
Let us establish the primary drain first, the internal jugular vein, or IJV. It is a massive vessel, and it is the principal venous drainage for the entire brain.
Where does it start?
It originates at the very base of the skull, exiting through the jugular foramen. Right as it exits, it forms a dilation called the superior jugular bulb. It collects all the blood from the dural venous sinuses inside the skull.
Including the cavernous sinus we've discussed so thoroughly.
Yes.
And once it's out of the skull, it travels straight down the neck.
Deep and protected. It descends vertically, securely enclosed within the carotid sheath, sharing that protective fascial wrapping with the internal carotid artery and the vagus nerve.
Does it pick up anything else on the way down?
Along its journey down the neck, it receives major tributary veins from the face and throat, like the common facial vein, the lingual vein, and the thyroid veins. It finally terminates at the root of the neck by merging with the subclavian vein to form the brachiocephalic vein, ultimately dumping into the heart.
So the IJV is massive, deep, and heavily protected. But the other main vein, the external jugular vein, or EJV, is a completely different architectural concept entirely.
It is.
It is completely superficial. You can actually see it bulging on the side of people's necks when they shout or strain.
You can see it because it lies just beneath the skin. The EJV is formed near the angle of the jaw by the union of the posterior auricular vein and a branch of the retromandibular vein.
So it stays on the surface.
Instead of diving deep, it courses superficially, running diagonally straight over the massive sternocleidomastoid muscle. It is covered only by the skin and a whisper-thin sheet of muscle called the platysma before diving near the collarbone to join the subclavian vein.
Because it is so utterly exposed on the surface of the neck, it must be highly vulnerable to lacerations and trauma. But you mentioned earlier that this exact superficial placement serves an incredibly useful clinical purpose.
It does.
How can clinicians use a patient's neck as a diagnostic tool?
By using the external jugular vein as a built-in venous manometer. A manometer is an instrument used to gauge the pressure of a fluid.
Okay, so how does that work in practice?
Under normal, healthy cardiovascular conditions, if a patient is lying supine, for instance, reclined backward in a dental chair, the systemic venous blood pressure is relatively low.
Right.
The EJV might be slightly visible right at the base of the neck, just above the collarbone, but it should not be noticeably swollen or distended higher up the neck.
But what if you recline the chair and you look at the patient's neck and that external jugular vein is bulging like a thick blue cord all the way up the side of the neck right up to the jawline?
If we connect this visual cue to the broader mechanics of the circulatory system, a severely engorged EJV in a resting supine patient tells us that the pipe is backing up.
Backing up where?
We trace the path. The EJV empties into the subclavian vein. The subclavian vein empties into the superior vena cava. The superior vena cava empties directly into the right atrium of the heart.
So if the EJV is visibly bulging against gravity, the pressure isn't originating from the head pushing down. It is a shockwave of pressure backing up from the heart pushing up.
That is the mechanical reality. It heavily points toward failure of the right side of the heart.
Heart failure.
Yes. The right ventricular pump cannot effectively handle or pump the volume of blood it is receiving from the body. Because it cannot pump it forward, the blood stagnates and backs up into the systemic venous system.
And you can see that on their neck.
The increased pressure inside the thorax transmits directly up the valvulus venous columns and visually manifests as severe, obvious engorgement of the external jugular vein.
So a dentist, preparing to do a routine filling, leans the patient back, sees this bulging cord on the neck, and knows instantly that the patient's heart is failing.
It is a massive clinical red flag indicating severe hemodynamic compromise. The patient requires immediate medical referral and cardiological evaluation. Elective dental or surgical procedures must be halted immediately, as the patient cannot physiologically tolerate the stress or fluid dynamics of the procedure.
It is amazing how much vital systemic diagnostic information is sitting there, literally just millimeters under the skin, if you know how to read the anatomical map.
Which brings our conceptual model full circle, really. We are not studying names, we are studying structure in service of function.
Let's synthesize this incredibly dense map. We have traced the high-pressure delivery and the low-pressure return. Looking back over Hyatt and Gartner's model, what are the overarching key takeaways we want to solidify?
First, we must recognize the profound redundancy designed into the superficial arterial supply.
The anastomoses.
Exactly. The extensive anastomotic networks, like the chaotic convergence we detailed in Kieselbach's area on the nasal septum, or the complete arterial rings encircling the lips, they ensure that these highly active superficial tissues survive even if a specific local branch is lacerated or compromised.
And the second takeaway.
Second, the strict, almost ruthless division of systemic labor. The external carotid artery is tasked with the complex, overlapping, functionally dynamic needs of the face and neck.
While the internal carotid just goes straight to the brain.
Right. It's an exclusive...
Exactly. Those valvulus veins likely evolved as a brilliant survival mechanism to allow for the rapid equalization of intracranial blood pressure and the thermoregulation of the brain during intense physical exertion.
Oh, of course.
Think of early humans engaging in persistence hunting on the hot African savanna. When you are sprinting, tracking, or repeatedly bending down, your brain needs a way to instantly buffer hemodynamic pressure spikes and, crucially, dump excess heat so the brain tissue doesn't cook.
The valveless venous pools act as massive bidirectional heat sinks and pressure release valves. The blood can ebb and flow freely to cool the cranium.
But this very adaptation, the open gate system designed to keep an early human alive while sprinting after prey in extreme heat, is exactly the same mechanism that makes a modern-day pimple on the nose or a misaligned needle during a routine dental injection potentially lethal.
The anatomy hasn't changed.
Structure serves function, but in solving one physiological problem, it always leaves a back door open for another.
It is a sobering, beautiful, and entirely accurate perspective on the compromises of human anatomy.
Goodbye to you, the listener. We hope you've enjoyed building this three-dimensional map with us, moving beyond the textbook page and into the living anatomy. Let's move directly into our learning reinforcement to solidify these vital clinical correlations. Learning reinforcement?
A patient turns their head sharply to back their car out of a driveway and suddenly loses consciousness. Which of the following anatomical structures is most likely hypersensitive in this patient? A. Carotid body. B. Carotid sinus. C. Pterygoid venous plexus. D. Subclavian artery.
B. Carotid sinus.
The carotid sinus is a dilation at the bifurcation of the common carotid artery that monitors blood pressure. Hypersensitivity, carotid sinus syndrome, can cause a sudden drop in blood pressure and heart rate upon slight head movements, leading to a loss of consciousness. The carotid body, A, monitors blood chemistry, not pressure.
An older patient experiences sudden, painless, and total blindness in one eye. An embolus is suspected. Which branch of the internal carotid artery system is most likely occluded? A. Supraorbital artery. B. Lacrimal artery. C. Central artery of the retina. D. Sphenopalatine artery.
C. Central artery of the retina.
The central artery of the retina is a tiny branch of the ophthalmic artery from the internal carotid. Because it is an end artery with very small branches, blockage by a small embolus causes instant and total blindness.
A dental surgeon is attempting to ligate the bleeding source of an injured sublingual artery following a floor-of-mouth procedure. If the artery does not arise from its normal source, the lingual artery, from which alternative vessel is it most likely branching? A. Submental branch of the facial artery. B. Inferior alveolar artery. C. Ascending pharyngeal artery. D. Maxillary artery.
The submental branch of the facial artery.
The sublingual artery normally arises from the lingual artery. However, clinical anatomy dictates it may occasionally arise from the submental branch of the facial artery, complicating surgical ligation during emergencies.
A teenager develops a severe infection from popping a boil on their upper lip within the danger zone of the face. The infection spreads to the cavernous sinus, causing a life-threatening thrombosis. What anatomical feature of the facial venous system facilitates this retrograde spread? A. High arterial pressure pushing venous blood backwards. B. The absence of directional valves in the facial vein. C. Direct connection of the external jugular vein to the brain. D. The carotid sheath acting as a physical conduit.
B. The absence of directional valves in the facial vein.
The facial vein and its communications, like the ophthalmic veins and pterygoid plexus, lack valves. This allows blood and potentially infected clots, thrombophlebitis, to flow in either direction, including backwards into the dural venous sinuses of the cranial cavity.
A dentist places a supine patient in a reclining chair and notices severe engorgement of the patient's external jugular vein distended all the way to the base of the mandible. What underlying clinical condition does this venous manometer sign most likely indicate? A. Carotid sinus syndrome. B. Thrombophlebitis of the facial vein. C. Right-sided heart failure. D. Epistaxis.
C. Right-sided heart failure.
The external jugular vein acts as a venous manometer. In a supine patient, significant engorgement above the clavicle indicates increased venous pressure in the thorax, heavily pointing toward failure of the right side of the heart, requiring immediate medical referral.
Following facial trauma, a patient presents with severe epistaxis, nosebleed. The bleeding is localized to the antero-inferior region of the nasal septum, Kisselback area. Which terminal branch of the maxillary artery heavily supplies this anastomotic region? A. Greater palatine artery. B. Sphenopalatine artery. C. Middle meningeal artery. D. Inforbital artery.
B. Sphenopalatine artery.
The sphenopalatine artery, the terminal branch of the pterygopalatine portion of the maxillary artery, enters the nasal fossa to vascularize the conchian septum, making it a primary contributor to the anastomosis in Kieselbach's area, a common site for epistaxis. Here are the details of this episode.
Vascular supply of the head and neck, the rivers that sustain and spread. Byline. Where blood flows, life is sustained, but also where it flows, danger can travel unseen.